Hello, this is Dr. Birnbaum from West Anaheim Medical Center talking about advances in resuscitation and therapeutic hypothermia. What we're going to be talking about is some of the new things coming through the pipeline regarding cardiac arrest, not for drowning, not for overdose, not for pediatric, but what we assume is a primary cardiac arrest. First, I'm going to talk about what we currently do during codes. We've got essentially four things. We've got ACLS meds, we've got chest compressions, we've got defibrillation, we have airway management, ventilation, intubation. I want to talk about what has been shown to help with good studies. Three things essentially. Number one is good compressions. Number two is early defibrillation. And the third is therapeutic hypothermia, which is the focus of this talk. What has not been shown to help in well-designed studies? Medications. Even the American Heart Association, who puts out all the algorithms, has admitted that no medication has been shown to improve survival in cardiac arrest. Interesting study that came out recently was published in JAMA from Norway, took 851 patients. Half of them were randomized to getting standard CPR, and half of them got CPR without any medication, so just chest compressions, defibrillation, airway management. What they found was there was no difference in long-term survival, no difference in survival to hospital discharge. The only difference is that more of them got a pulse back temporarily but died before leaving the hospital. Along the same line, intubation has not been shown to increase survival in cardiac arrest, and there's a couple of reasons it may be harmful to do it early. One is that the positive pressure ventilation, either from the intubation or from a bag valve mask ventilation, actually puts pressure on the vena cava and decreases the blood flow that's returning to the heart. So the heart is pumping without as much blood in it, so it's not going to pump as effectively when you're doing the chest compressions. Second is that during intubation there's often a pause in chest compressions, which we know is harmful. So when the patient gets a pulse back, what can we do? And this is where we get to therapeutic hypothermia. Now the evidence for this, there's many studies, but the two landmark studies I'm going to go over. Both of them are from 2002, were published in the New England Journal of Medicine. There's a hypothermia after cardiac arrest study in Europe. They took approximately 290 patients and randomized them to getting therapeutic hypothermia or not. Out of the therapeutic hypothermia group, 55% of them were able to live independently and work at least part-time, whereas only 39% of the ones without it were able to have a good outcome, as described above. Same year in New England Journal of Medicine, there was a similar trial in Australia. 49% of the ones in the therapeutic hypothermia group had a good outcome, whereas only 26% without it had a good outcome. Bottom line is the number needed to treat, which is basically defined as the number of patients you need to treat to have one of them have a good outcome that otherwise would have died or remain neurologically impaired, is 6. This has been endorsed by the American Heart Association International Liaison Committee of Resuscitation since 2003. And you can see on the screen, basically, there's a strong recommendation when the initial rhythm is VFib, and for other initial rhythms, they say it may be beneficial. Not as strong of a recommendation for asystole and PEA. VTAC is kind of in between. Who are we going to do this on? Inclusion criteria, the main one is that they are in a coma, which means basically they have a GCS of less than 6. If they're awake and they're talking to you, they're not going to get this. And the initial rhythm that is most likely to be beneficial in this would be VFib. VTAC is also probably going to be, it will probably be beneficial to have therapeutic hypothermia after VTAC as well. Whether it's helpful for PA systole is a little unclear. Under our protocol, we can do it on this. It'll be up to the doctor. But there's not as much good evidence showing that it'll be helpful. Exclusion criteria under our protocol, they're DNR or the family doesn't want it. They're unable to, at baseline, unable to perform their activities of daily living, and they're not living independently pre-arrest. The third one is if they have an active intracranial bleed, or coagulopathy, major surgery less than 2 weeks, or you think it's a cause of a cardiac arrest other than a primary cardiac arrest. The final one is hypotension despite fluids and pressure. So if you give them fluids, you put them on dopamine, their pressure comes up, you can still initiate therapeutic hypothermia. You have to be a little more careful with these patients, though. As far as age, there's no upper limit. Rhythm we've already discussed. There's no clear-cut downtime cutoff. There were patients that had up to 75 minutes of resuscitation attempt prior to getting a pulse back and still had a good neurologic outcome. In the European trial, they used a 60-minute cutoff for downtime prior to getting a pulse back. Question always comes up, can they still get TPA if they're put under hypothermia? Yes. Can they go to the cath lab while they're cooled? Yes. It doesn't really affect heparin, aspirin, TPA, cath lab, or which antiarrhythmic drugs you give. As far as arrhythmias being a contraindication, the only real contraindication would be sustained VTAC. Non-sustained VTAC is not, AFib is not a contraindication, PVCs are not a contraindication. So how do we do it? First of all, we need to know what their temperature is. We're going to put in a bladder or rectal temperature probe. With our GAMAR unit, it comes with a rectal probe. We need to do a good pre-paralysis neuroexam, document that their GCS is less than 6, document brainstem reflexes, presence or lack of any respiratory effort, draw labs, blood cultures, and if there's a question of intracranial bleed, they need a head CT. Next, they need to be intubated if they haven't been already, and respiratory therapy needs to remove the heat exchanger from the vent. Next step, they need to be sedated and paralyzed. Once patients get cooled, they start to shiver. Shivering warms them up, and we don't want this, so they can be paralyzed with vecuronium or Pavulon. If anybody who's paralyzed needs to be sedated so they don't realize what's going on and are in a state where they're unable to show you.